This space. Okay, hi everyone. Welcome to Introduction to Epidemiology. Okay, so this is a relatively new topic, so I'll go slow. Okay, some of you may have some background in epidemiology. It's okay. Just take it as a revision. Okay, first thing is to talk about the scope. So we'll cover a few things. How to remove this?
You can drag it.
Okay. So first, understand the definition, the scope, and history of epidemiology. Okay, that's the definition part. Next, the why. Always important before doing anything is know why. Why do I need to know epidemiology in the context of public health? Certain measurements of disease frequency and association. I think Charmaine just mentioned about incidence prevalence. I think she went through a course previously, so it'll just be a recap. Also recognize the significance of data collection, analysis, and interpretation. So today is an introductory course. We have other topics that will be ongoing to elaborate further. So we will not go into much details. It's just an overview, broad picture. Okay, any question before I continue? Okay, good. So first thing first is this, anyone know who is this person?
Jon Snow.
Yeah, it's actually hidden here. So it's a test where you can read. Okay, no, anyway. Yeah, anyone who know what is Jon Snow? Oh, you all know. Oh, that's great. Anybody else? Okay, good. So those don't know Jon Snow, so you can consider as sound like a father of epidemiology or some very big shots in epidemiology. Okay, first, the way I think of epidemiology is very straightforward. It's just time, place, and person. When did this happen? Is it in the past, now, or future? Place, where did this happen? Where is the disease? And person, who is the one getting the disease? This is my way of remembering it. Time, place, and person. But of course, this is a more formal definition. Distribution and determinants of health-related states or events in specified population, and how you can use this to control health problems. So a few scope, disease surveillance. Anyone know what is disease surveillance?
To look out for disease.
Yes. Okay, what it means is there is some disease going on. We want to see what is the rate, the frequency. Is there any changes? For example, there's this thing called flu or influenza surveillance. So whenever there's a shock in the number of patients with a certain type of a flu type, then you can kind of like postulate that maybe there'll be an epidemic soon. There'll be a lot of cases coming up. So you need to do a surveillance. For example, COVID, now that COVID is more of an endemic. Okay, endemic simply means that the number of cases is the usual, no more than the usual. That's called epidemic. Sorry, endemic. Yeah, epidemic is more than usual, and pandemic is more than 2 continents. Right? These are the formal definition. But we stick to this. So disease surveillance means you're looking at the current state. Any changes? Is it too many? Is there any shift from, let's say, strain A to strain B? That's why in the news you read about all the COVID vaccine, the Omega, all the different changes. They're trying to monitor it. Okay, outbreak investigation. So basically, there's a few cases. Anyone remember the bite dance? Okay, so what happened was there was some food poisoning cases. So outbreak is usually more than 3 cases. Yeah, so there's some definition. So you need to have a few cases, more than usual, then you actually go and investigate. Yeah, because especially if it's the same place, for example, if someday we had a outbreak of diarrhea in our department meeting, let's say today, what is the likely cause?
Mooncake.
Yes, the mooncake. Or it could be something else. It could be water drink. So these are some things you look at. So this is from a person. Okay, I mean place. Okay, and timing. So you can use this for analytical research and health policy development. Okay, so back to this. Anyone know what's cholera?
Or you drink bacteria, then you get diarrhea.
It's a contaminated water source. Okay, so we'll give you a bit of a history of why epidemiology is important. So this is the cholera outbreak. So in the past, there's this thing called miasma. It's basically bad air. So they thought that disease is due to bad air. So if you have good ventilation, okay, then it will reduce disease. May or may not be true. So that was a prevailing theory. Then Snow, okay, Jon Snow have a hypothesis. Cholera, is it spread through water or is it air? That's the question. Okay, I think you can't really see here. But what happened is these are the cholera cases. Okay, and they found that they actually linked to this area here. This central area is called the Broad Street pump. So there was a pump here. Okay, so all the cases all clustered around here. So in all the cases clustered around here, you want to experiment whether is it due to something here. That is the Broad Street pump. So this is a system. So remember spatial distribution. Last time don't have such complicated geospatial. So what they do is just map out all the cases to see if there's anything of common. Yeah. They also do this for crime. They solve crime. For example, victim A is here, victim B is here, victim C is here, victim D is here. Then there's a pattern. Maybe the murderer is actually staying around this area. I mean, this could be a is if they have nothing, this is somewhere you can look for. Okay. So what I did was he actually asked the local authorities to remove the pump. So once the pump is removed, the outbreak stopped. So there's strong evidence that there's this transmission through water. Okay, this is a simplified story. There's a more complicated story, but let's not ruin the fantasy. So actually, this is the idea that somebody came up with the idea, and then they kind of tested it, and then after that, after removing the pump, because very simple. If you think it's not due to the pump, then you just remove it because you think it's not due to it, right? So after you remove it, it stopped. So maybe it's due to a pump, maybe something else. I don't know.
Wait,
But yeah.
This before the germ theory.
Yeah, definitely before germ theory. This was the miasma theory. Yeah, because germs can't be seen, microorganisms. Actually, you look at medicine, right? So we should not be so proud and so arrogant because a lot of time medicine have a lot of mistakes, a lot of errors, and time took many years before all this become mainstream. So we should be more humble. Don't assume they're always right. So maybe diabetes is not caused by whatever, can cause something else. Who knows? Things change. Yeah. Okay, anyway, this is the evidence. Okay, I'm third. I forgot. Okay, good. Okay, so back to the role. So there are 4 roles. There are more than that, but we look at 4 main roles. The first role is to monitor and describe health status. Why is this important? I think Matthias just did it today. The ACSC condition, remember? We want to monitor and you want to see if what's the trend. Is it increasing or is decreasing? Usually when it's increasing trend, it's something worrying because it may go higher and higher until a level that is not acceptable. If it's the decreasing trend, that's good, but sometimes you can ask yourself, can you do better? Okay, if it's steady, then sometimes you need to ask yourself, can you do something to reduce it? Okay, that's called monitoring and describing the health status. Next, identify risk factor for diseases. I think we kind of did it, right? So what's the risk factor for pneumonia? Anyone remember just now?
Diabetes.
Okay, but in his paper was more of influenza vaccination. If you're not being vaccinated with influenza, there's a higher risk of hospitalization due to pneumonia. So this is one of the risk factors for a hospitalization due to pneumonia, not being vaccination. May or may not, but there's no causality, but it's just a hypothesis, need to test it. Okay, yeah, but right, diabetes, because your immune system is affected, so it's another risk factor for pneumonia or infection or hospitalization due to pneumonia. Okay, public health policy and strategy. Of course, based on this, we can form our policy. And then how do we intervene to reduce the spread of diseases? For example, when you found that COVID was spread through close contact, what was the public health policy or strategy?
Safe distance.
One is safe distance, isolation. So anybody from overseas with a case, isolate, don't talk so much. Isolate, put into a place, wear all your suit, don't let the person get in contact. Okay. And over time, they realize that the incubation period is about 7 days, 14 days, 10 days. It really depends on how safe you want to be. And that's how they manage to isolate. So there are a few strategies. Then another one is called I don't know what the term is called. Another one is called distancing. Yeah, I mentioned just now social distancing. So we cannot stop it from spreading, but we can reduce the spread by having safe distance. People work from home, reduce the mixing. So this is how you can reduce the spread. Yeah. I'm not sure whether we had our National Day during COVID. Was there? I can't remember. Huh? Virtual, right? Yeah, see, that's one way. So we prevent any situation where there's a large crowd consolidation. This is some of the policy and strategies to do that. For diabetes, I'm sure all of you heard of the war on diabetes, right? So what the strategy was to label the drinks. So all drinks that are canned, all these, you realize there's actually a label now, A, B, C, D, and E. Anyone read it? Okay, so if you can take A and B is very little sugar. Anything above C is considered added sugar. So we are more concerned with that. So there's some ways you can reduce it. Yeah. Okay, then next thing is our department also do evaluation. So evaluate the intervention and the control programs. For the example, there's some intervention, does it help? And so on. Okay, let's go a bit more details. First thing is, this is the registry. Okay, so many years ago, I actually went to the National Disease Registry Office, NRDO, National Register of Disease Office, okay, to actually, I think it's a HPB, Health Promotion Board. So you can actually go down with all the data on AMI. I think someone asked about AMI just now. Acute myocardial infarct, cancer registry, kidney failure registry, stroke registry. So these are 4 registry you have, okay? And then any cases are in the registry. So these are data collect. So for example, for kidney failure, we found that there was a trend of increasing, and then it decreased or slow a bit, and now it's increasing again. So in Singapore, one of the highest, we are one of the highest diabetes-related kidney failure in the world. Number 1 is Mexico, Jalisco. Number 2 is Taiwan, and then you are the third. Okay, there was some data there years ago. I'm not sure the latest data, but we are among the top 4 diabetes-related kidney failure. So interesting, right? Why? That's a question. Okay. So anyway, so this is about registry data. So you can look at data, you talk about the things I mentioned, time, place, and person. So you talk about yearly trend, year on year, is that increasing number? That's the time. Person, who gets it? Male, female, Chinese, Malay, Indians, others. What else is there? Time, place. Where are they from? Are they from the hospital, or are they from the GP or polyclinic? Where are they from? Yeah, so these things they can sometimes you may even map areas. Singapore is too small, so maybe may not. But overseas, when they are bigger country areas, they can actually map the northern part, the southern part, see which areas are the one with the disease. So that is the disease mapping, geospatial mapping. Okay, anyone heard of this National Public Health Survey? Okay, there's a few. We have the Pop Health Survey, we have the National Health Survey. The key difference is some is their blood tests, so they will actually do a proper one. Some is through self-reported, they'll ask you questions. So there are different design. Suffice to say, it's good to compare across time, and hopefully the design is the same. It's very difficult. So this is a cross-sectional. Cross-sectional means that on the year itself, they monitor health and risk factor. Okay, so the key thing to know about cross-section is they don't always ask the same person. So it's a sample. So they sample people in the population to do a cross-sectional one. There are some research is cohort where the same person is being sampled many times. So that's called a cohort study. But this is more cross-sectional. Okay. The bad thing of cross-sectional is there's no causality because it's only cross-section. A cause B or B cause A, you don't know. For example, you found that a lot of people have drink sugar water, and then there are a lot of people of these people have diabetes. So is it that you drink sugar water cause diabetes, or because you have diabetes you like to drink sugar water? That's why causality is not that easily determined. So for a lot of cross-section study, it's only for association. Causation is a higher level, which will cover, I think, in a couple of weeks' time. Okay, you look at risk factor. Remember that's what I mentioned, risk factors. So you also want to find what are risk factors. So if you are obese, what are your risk factor? For example, maybe lack of exercise, or you have a bad diet. So all these are risk factor for obesity or risk factor for diabetes, as well as your lifestyle practices. How much exercise you do? Do you know anyone know what is the recommended number of amount of exercise you should do in a week to maintain your weight? Very good. 150 minutes is to maintain your weight. It's not for you to lose weight. So you want to lose weight, you need to do more than that. And you need to do at least moderate exercise. Yeah. Do you know what's moderate exercise?
30.
Yeah. So the simple thing is, can you sing? Okay. If you can sing, means not moderate enough.
Oh.
Yeah. If you cannot talk, it means vigorous. So that is one of the easier. So when you run, you can still sing, can still talk, right? And not much. Yeah. So you should not be able to sing. Yeah. When you do a moderate exercise.
It should be until you cannot. How should I describe? Like it should be moderate enough, but not too much.
Depends on your age whether you can take it. Yeah. For me, I cannot take it. You can probably run to the state that you cannot sing.
But like that is like you
cannot talk, sorry, you cannot
air.
talk. Yeah. So that's okay. So that's why okay. You have been through army.
Yeah.
You did IPPT before, the 2.4 run. After 2.4 run, are you able to talk or sing? Probably not immediately, right? So that's the level of requirement is quite strenuous lah. So that's how you get. But one way is to measure heart rate. So in the past, not easy to measure heart rate lah. Some people don't even know how to measure. But now with Fitbit, all these things, you can just measure heart rate. From what I heard, every recruit is given a Fitbit now. I heard, yeah. So those with children or those with nephews or nieces, maybe they see that. So you're actually given a Fitbit. So it's easy to measure heart rate. So there's a formula. You can take the maximum heart rate minus your current heart rate, and they'll calculate, take your age minus your maximum heart rate, then you can know what's your target heart rate, and you can see how much percent is that. Okay, then just like I show you the formula. Yeah, so this is about exercises lah. Okay. Okay, any question before I move on? I hope I'm not going too fast. Okay, good. Okay, now about risk factor. The most famous study, which most people cover, is called Framingham Heart Study. Ever heard of it? Framingham Risk Score? No. Okay, so this is a place I've never been to there before. It's in Massachusetts. Okay, so I haven't been here before. I've been in Boston. I think it's quite nearby. Okay, I hope. But anyway, so what happened is they follow a group of this is called cohort study. So they follow a group of people living here over time. So they find what are the risk factors. So all these are the captured at a baseline, whether they got high blood, high cholesterol, smoking, whether they are fat, whether they got diabetes, whether they have physical inactivity. Okay, and then they found that for those with all this, the risk of getting heart attack or heart disease is higher. So these are the risk factors for having this. So this introduces the concept of risk factor. So to find risk factor, straightforward, you actually measure at baseline. So among patients, amount of population without heart disease, you measure all this. Some people with hypertension will develop heart disease. Some people without hypertension will also develop heart disease. Then you compare the rate. They found that those with hypertension, maybe the rate is 10%. Those without hypertension, the rate is 5%. Then from there, you see, because this is a cohort study, they actually follow up the patient. So you cannot, there's a causality. Because it's thought that they have heart disease, then they develop hypertension. It's the other way around. You must first develop high blood pressure first. Then they look at whether you have higher chance of having a heart disease in the next 5 or 10 years. Okay, so this is the idea of a cohort study. We shall cover more of this in future. Okay, so this is how to identify risk factor. Okay, move on. Okay, next about guiding public health policy and strategy. Okay, anyone heard of smallpox? So, okay, good. So recently what happened was that there's monkeypox. Anyone heard of monkeypox? So the speculation, again, speculation, all those who are older, who have been vaccinated against smallpox, they may have some cross immunity towards monkeypox. Yeah. Same thing as during COVID. During COVID, there was a lot of studies saying that maybe those with TB vaccination, I think now not much. So those with TB vaccination, they have a higher protection against COVID. So this was before the COVID vaccine was being created or widely available. Okay, so anyway, the story of smallpox is a success in public health. How we eradicate it is because there's always some small reservoir of disease in certain parts of the world. And what we did was, what they did was they actually sent teams towards the deepest part of the Amazon forest. People there. Okay, in general, we are not supposed to touch the indigenous people because we do not want to affect their way of life. Okay, I can't remember what was the story.
Introduce disease to them.
Yes, I wanted to talk about the Spaniard. Okay, so what happened was the Spaniard came and then they actually destroyed a lot of Native Americans. Yeah, that was the theory that diseases are spread. That's why there are some countries, you're not sure, have you been to Australia? You're not supposed to bring food, you're not supposed to bring even dirt, because all these things may affect the plants and the animals. That's why they make sure they don't have all this, always be fine.
Actually, the smallpox is quite interesting because the reservoir is only human.
Yes.
It doesn't go into other animals. So it's easier to
eradicate. Yeah, but there's also cowpox. Okay, so you go back to, everyone know what is cowpox and what is Edward Jenner?
The other.
Okay, not so much. I'll go back. Okay, so Edward Jenner, what happened was last time smallpox, there wasn't any vaccine. So they found that people with cowpox, those mates, they have lower risk of getting smallpox. So he speculated that maybe the cowpox may help. So what they did was he actually got those with cowpox, I think. Those with then they get the scabs, all the bacteria, dead bacteria. Scabs are all the dead bacteria. Then it injected into a boy. In the story, it was his son, but I don't think it's his son. But anyway, he injected to a boy and then they exposed it to smallpox. And he found that those with that didn't really get smallpox. So that's the start of vaccination. Okay, so now it's not possible because IRB not definitely no. Yeah, so ethics everything lah. But that was the story lah. If you're interested, I can talk about that. Yeah, but yeah, good. Okay, so where are we now? Okay, next is chronic disease management. So this is how to develop DASH. What's the DASH diet? Anyone heard of the DASH diet? Low salt, high potassium, take a lot of fruits and vegetables. That's a DASH diet. It's to prevent hypertension, high blood pressure. So if you want, you can take cucumber. Apparently, cucumber is quite good for reducing blood pressure. Celery, all these things are good to reduce blood pressure. Yeah. Banana, maybe bit high sugar, but good to take those low calorie ones. Yeah, all these things have high potassium, so some of them actually reduces the this. Okay, I'm not a dietitian, so I can't really talk more about DASH diet, but if you're interested, how you find out. So they found that this is quite good. So exercise guidelines also based on epidemiology study. So what they did was they look at people who exercise, people who don't exercise, then they look at who actually have a better outcome. Then from there, they came up with the guidelines. For example, the 10,000 steps. You know who came up with 10,000 steps? It's not real lah. The 10,000 steps, I think during one of the Olympics, the Japan wanted this thing called a 1,000 step tracker. So that's why I came up with the 10,000 steps, but actually it's not real lah. The real evidence they found during epidemiology study, I think it's 7,500 or something like that. There's a 7,000 that is the optimal number of steps for best. Because if you walk too much, you can also have stress onto your joints and things like that. Yeah, so we talk about evidence-based. If you go and Google it, the evidence-based, I think it's 7,000 plus. Then there's always this U shape. Yeah. Okay, infectious disease control. We just been through COVID. So straightforward contact tracing. So I was more involved in contact tracing. So what contact tracing? Very simple. You just call the person and say, who have you been contact with? So those who be contact with, too bad. All needs to stay at home. Yeah, this is called contact tracing. So contact tracing is actually more suitable for things that are more intimate. For example, sexually transmitted disease. Okay, because you don't randomly have sex with a lot of people. Okay, maybe now people do. But in the past, people don't randomly have sex with everyone. So which means that who you have sex with, you know, and you can contact the person to ask them to go test it. This is called contact tracing. But in face of COVID, it's very difficult. So what I did in COVID was to find where do you go? Where do you go? So from where do you go, we can isolate the potential source, and then we may want to vaccinate or test out some area. So I'm not sure. I think there was some area. I think one of the hawker center was closed down. I think Red Hill Hawker Center was closed down, and then all the people have vaccinated or had tested or something like that. Yeah, or the even market. So what they do is they will just shut down the market and do a deep washing. Okay. And quarantine, I think some of you know, right? So those with infectious disease are quarantined. So in the past, Singapore, right, because a lot of people came to Singapore, they have some disease while traveling, they're all quarantined at St. John Islands. So there they are there. You watch, anyone watch 雾锁南洋? What's that? Oh my God, what's the show called in English? There's a very old TV show, not TV, TCS show, Channel 8 show. It's about these people from China coming to Singapore. And in the one of the scene is that they came to Singapore, they go to St. John Island, then they'll spray water to clean themselves all the dirt and wash. Yeah. But you should understand when you're oh, somebody call me. Give me a minute. Hello? Hi. Hello? Yes? Very bad. Okay, so that is the thing. So they actually quarantine at the Central Island. So quarantine means until you're cleared, then you can come in. Yeah. Okay. So they take a few days, let the disease come about. Once the disease come about, of course, you'll be refused entry. For those without disease, then they can brought into the place. The vaccination, I think all you know, I just prevented COVID and things like, and we just went through flu vaccine and pneumococcal vaccine. Okay, so this is how you control infectious disease. Okay, let's move on. Okay, evaluate intervention and control program. Okay, first thing is to establish baseline. Okay, very important. You need to know what is the baseline. Otherwise, you cannot compare. So when you do any research study, good to have a baseline. Once you have the baseline, for example, some people have high blood, some have diabetes. Then you do the program 1 year later, 5 years later, 10 years later, then you compare again. Yeah. So this is what you do for this, so that you can see how your intervention affect the population. So you must have a baseline. Otherwise, if you don't do a baseline, let's say at the end of the study, you found that 20% have diabetes. But what's the baseline? You don't know. Maybe already before anything starts, 20% already have diabetes. then your intervention doesn't do anything. Yeah, so you need to do a baseline, maybe 30% have diabetes. Then after that, after the Tanato diabetes reversal program become 15%, then you can say that half of those with diabetes manage to reverse or recover or go to remission. So the program is successful because baseline is 30% diabetes, and end of the day, 15% have diabetes. So you reduce it by 50%. Key indicator. So you need to define, otherwise this is very important. We have a key indicator to know whether the program is successful or not. So at the start, you talk about your key outcome. So there are two types of indicator. You know difference process and outcome. So in the context of diabetes or hypertension, chronic disease, process outcome is how many patients have blood pressure measured. This is a process indicator. Okay, this is something that the provider has a lot of control over. So a lot of time we focus on process indicator. Okay, outcome indicator is whether the blood pressure is well controlled or poorly controlled. This one is not really up to the provider because patient may eat a bad diet, patient may not take the medication. Then how you expect outcome to be good? But you expect the process to be done. So you need to measure the blood pressure, you measure the blood test. So process indicator is usually what we do to measure the thing. For example, in our HSOR or department, our process layer could be number of publications submitted because submitted is we can control, right? We can submit 300 articles. Next is number of articles published. It's not up to us. Sometimes the reviewer take 10 years. Okay, not too long, 3 years to reply. Okay, there are some, so especially for those good journals, it may take a year or more. I'm a reviewer. Okay, I'm not editor for some journal. Some of them was submitted last year. Until now, I haven't published yet. So almost 1 year. Yeah, and my journal is a POS, so it's not very high impact. It's okay, relatively high impact. Okay, I shouldn't say that. But there are some journals that take even longer. Okay. So this is process and outcome indicator. Study design. This is a randomized control trial. Okay, randomized control trial is supposed to be the highest standard. What they do is you have a group of patients or people who are eligible for the criteria, and then you randomly decide one group will go for intervention, one group will not go for intervention. Why is this good? Why is randomized control trial the best or one of the highest evidence? Anyone know? Okay. One thing is that sometimes when you do randomized trial, right, there are things that you cannot measure. They will be randomly into these two groups. Okay, as contrast to if you assign people, there's always this selection bias. Let's say, for example, the doctor decide who to go. They look at this person, very likely to be compliant. Okay, you're in the intervention group. Then the other person want to come, you remind him many times. Then he put that in the control group. Then end of the day, he found that those in the intervention group perform better. Those control group never turn up. So he said that poor outcome. Yeah, but that's called selection bias. So we do not want to have this selection bias. So we have this randomized trial so that in theory, it will actually remove the effect of the selection so that the character, if it's done well, all the characters should be quite similar. So a lot of trial, if you have big enough sample, you randomize it, you have quite equal number of male, female, gender, things like that. But sometimes randomized trial can still be unbalanced, especially if the number is small. Yeah, so let's say you only have 5 Indians in a population of 100. So by chance, can be all in one group. Then too bad lah, because it's small number. But if you have big enough number, let's say you have 50, let's say 50 male, 50 female. You randomize the two groups. Most of the time, you get about 25, 26, 27 in one group. That's kind of statistics. So statistics can tell you what's the likelihood of the distribution in the two groups. Okay, that's called a randomized control trial. Quasi-experimental. Anyone know what is quasi-experimental? So it's not experimental, it's just quasi. So a lot of these called natural experiment. So maybe by chance you have one school you put as a control group, go for weight loss program. Another school you put as a that's a cluster design. So one group will have the intervention, one group will not. So this is not a randomized trial, it's more a quasi experiment. Sometimes you can also have phasing experiment. So one group you test now, you implement now, and then the other group you didn't implement, that will be a control. Then 1 year later, this group finish already, right? This group start the intervention, and another group will be the control. So this is phased in. It's like almost like experiment design. Then there's another one that is called a non-experimental, that is called a retrospective study. Means the data is already done. A lot of time we are doing this. Data already been collected. Then you're just trying to look back and see whether, for example, the study you did, patients with pneumonia infection. This data has already been collected. Then you compare how many have vaccination with flu, how many have vaccination with pneumococcal, how many have both vaccination, how many have no vaccination. They compare. So this is called retrospective database type of research. It's not really experimental. That's another form. Okay, collecting and yes. Okay, open label, straightforward. Open label means that you know that this is it open label or is it blinded? So open label means that they tell you that this drug is what. That's called open label. Another one is called blinded study. So blinded study means they don't want the person to know what they are taking. There's the thing called double blind, triple blind, not sure about quadruple blind. So blinded study means patient don't know what they're taking. Double blind means patient and the provider doesn't know what they're taking. Triple blind is the highest standard. Patient don't know, provider don't know, even the analyst don't know. Yeah. So it's just A and B. Don't even know which is good. So this is the highest form of evidence where it's triple blinded. So you can come across this. Open label, I think, is where the drug is known or where there's no blinding. I think I can find for you. That's a very good question. I always see this open label.
So they know what they're drinking lah. They are.
What is the control? What is the control?
Going to go through this OptiFast for 12 weeks and then
yeah.
Then the rest.
Okay, so open label is where the information is not withheld from the trial participants, so they know that they know what is it. If you want the OptiFast study to be blinded, what you can do is you can create a placebo that tastes and smell like OptiFast, but it's not OptiFast. Then you can blind it. But otherwise, something can blind like surgery. But it's interesting. Surgery should not blind, right? Some people got surgery, some people got no surgery. But the people who did sham surgery. What is sham surgery? Oh, good. Sham surgery means one group you cut and do the surgery. The other group you cut and you sew back. That's called really go to that. But yeah, is it sham surgery? Okay, so I think it is nowadays I think ethics very hard because sham surgery you cut you may cause harm, you know. Why is there a need to go to that extent? Surgery versus sham surgery. Okay, so there's a paper a couple of years ago. Every week, every December, British Medical Journal come out with a joke article. So you can always read about a joke article. So joke articles, do you always need a randomized control trial? You want the highest evidence. Do you always want a randomized control trial? Who say yes? All studies should be randomized. Okay, that's one thing. What else? Is it practical or not? So the example they give was, does parachute work? Can you imagine going for a randomized trial? This group, I give you parachute. This group, no parachute. Now jump. Okay?
One guy
jump
to his death.
Okay, I don't know that. But it's not funny. Or worst thing is one group with the parachute A, okay, one group with a fake parachute. Then go down. Then I'm in the control group. Okay, so not everything can be randomized. Basically, yeah, some things cannot randomize because it's not fair to give the control of fake or non-treatment for another group. Yeah, so that's why this is the issue. So some of the trial, what they do is, one group get cancer drug A, another group get the normal drug, the normal accepted drug, not placebo. It's a normal treatment, standard treatment. Because if you want to be randomized control, you should give him a placebo, right? Well, you know how evil that is. Person, people got cancer, there's a standard treatment. Instead of giving a standard treatment, giving a placebo just to prove that your cancer drug works. Yes. Yeah. Yeah. So cannot, right? So that's why not everything can be randomized control trial in that sense. Okay. Collecting, analyzing data, user surveillance, statistical method to evaluate. So this is what they do. I think just now, Pabinda, right? Impact study. So they look at statistical method to compare whether the impact study work. Yeah, big of things. And see whether how it works. Yeah, whether the group that had the intervention versus the group that doesn't have an intervention. Sometimes they do this thing called is it time series? No, they do this called period testing, historical control. So what they do is they do something, they compare with a historical control to see what in the past what happened. So but they'll have a problem with the temporal time comparability. Okay, try to go a bit faster. So evaluate things. You know how this thing called number needed to treat. Okay, very simply, what they do is that for certain condition, right, there's a certain number needed. This is called effect size. So 1 divided by the effect size will give you a number needed to treat so that they achieve the thing. For example, for my amputation study, we found that the number needed to screen to prevent one amputation about 200. So you need to screen 200 patients just to reduce one amputation. Yeah, so this is how you calculate. If you're interested in the future, I'll talk about that. Risk reduction. Okay, so you talk about that. These are how to reduce the risk. Let's say to take a certain things, how much risk can you reduce? Let's say vaccination. I think we'll cover that just now, right? If you take the full vaccination, what is your risk reduction versus somebody who didn't go for full vaccination? I think it was 67%, something like 61%. So there's a certain risk reduction if you're vaccinated. Okay, cost effectiveness. This one combines the data with economic analysis. So there are 4 types of cost effectiveness study. Okay, one is called cost minimization. This means that which intervention can reduce the cost. Next is called cost utility analysis. Okay, then there's a cost effective analysis. And the last one is cost benefit analysis. I still remember that 4 types of analysis. Okay, we can cover all 4 if there's interest, but that will be under economic analysis. And finally, it guides improvement. A lot of times we do program quality improvement. So this will give you some data to improve the intervention. Then part wants me go slow. So any question before go on? So far, we covered 10 slides only. I think I have to do slowly. Yes. Okay. Okay. Too fast, too slow. Okay, can move on. Okay, incidents. I think you mentioned about incidents. Just remember, incidents is new case. I remember by N. There's an N here. So new case. So it refers to a number of new cases of a disease occurring in a specified population during a time period. So there are 2 types of incidents. One is called incidence rate. Whenever we talk about rate, there's a time element. So it's a number of new cases per unit of person time. So 1,000 person year. This is called incidence. So you want to look at number of cases of diabetes. What you do is you must take the number of new cases of diabetes divided by the population that can have diabetes. So patients who already have diabetes cannot be in your denominator. They must be taken out because they already have diabetes. By definition, they can't have any new case of diabetes. Okay. And so on. Cumulative incidence is talking about a proportion of a population that become disease over a specified period. For example, 1 year. Okay, so these are the 2 things you need to know: incidence rate and cumulative incidence. But actually, a lot of times they're all mixed up. So just make sure you know what you're talking about. Whether just don't know incidence, new case, and new case. So once you know incidence, the next one is called prevalence. Okay, prevalence is the total number of cases in a disease population. It's easier to calculate because the denominator is the population with and without the disease. So there's prevalence. So there are 2 types of prevalence: point prevalence and period prevalence. Period is the easiest over a period time. Point prevalence is talking about mid-period, start period, end period. There's a starting point, there's a cut-off point. Okay, the definition is also, again, people just talk about prevalence. We talk about point prevalence or period prevalence. Okay, they use very loosely. So all this is all the academic. So if you're talking about presenting to a professor, then you must be very clear. Are you talking about point prevalence at a specific point in time, mid-period, or talking about period prevalence? You're talking about a period. Why this matters is because of denominator. Your population, okay, Singapore may be a bit stable. For some population, right, the starting population and the end population is not the same. So what happened when the start? Let's say the start of the population, that's 2024. 2024, January, you have 1 million. Okay, December, you have 1.1 million. Okay, so what's the population size? 1 million or 1.1 million? Okay, January, you have 1 million population. December, you have 1.1 million population. So do you use 1 million, 1.1 million, or what?
Percentage.
Okay, so if it's point prevalence, very simple. You ask yourself, are you talking about January, the point, January, they use 1 million? Or are you talking about the December, the point, okay, 1.1 million? Or June, then you tell me what's the population in June. You cannot tell me that I estimate to be halfway. Okay, so this is called point, okay? Or period. Period is just start and end. So period, you can take the average, okay? Or you want to be very specific, let's say January is 1 million, February is 1 million, March is 1.03 million and so on. Then you can calculate the weighted average of the population. Okay, so I'm going to be of details already, but you can see the calculation can be differ whether it's a point prevalence or period prevalence. Okay. Okay, let's move on. Next, we talk about mortality rate. Again, very common, right? We always talk about death rate. I always call this death rate, very sad, the sad topic to talk about death rate. So it's how many people die in a defined population during a specific interval. So mortality rate, is it an incidence or is it a prevalence rate? Can you die more than one time? So most of the time, most likely an incidence, right? Because you only die one time only. So once you die, that's it. There's no such thing as new death. Only one death. You only die one time. Okay? Yeah. So that's why I use the crude mortality rate. Crude means any cause, all cause. Okay. So crude, not adjusted. Okay. Crude is not adjusted. Maybe my jokes is crude, so not adjusted, not filtered. So total number of deaths in a population over a period. Okay. This is a crude mortality rate. Okay. Over a period. Okay. To be fair, it could be a crude mortality rate. Okay. Whatever. Next is cause specific. So why you want cause specific? Because let's say I talk about diabetes. ACSC, you talk about diabetes, you really want to be diabetes specific mortality rate to be clear, right? Because you don't want people to die of a road traffic accident and then after he has diabetes and you say that, or because he has diabetes, that's why he got a road traffic accident death. Not really correct. But if you in real life, you most of the time just use this because we don't have the cause of death. Okay, even a cause of death, you need to start arguing really. So is it because he got diabetes, he cannot see clearly, that's why he got killed by the car? You don't know, no? Yeah. Or because he got diabetes, he felt giddy. That's why a car killed him. Okay. So all these are possible, right? Yeah. Or because he got diabetes, his leg is weak. That's why he got killed. Or he got killed by the hit by the car. A small cut. Normal people will survive. But because he have diabetes, the cut become infected. He didn't go for amputation. Then because he didn't go for amputation, there is a complication and then he died. So if he didn't have diabetes, he wouldn't have died. So the road traffic accident, is it a road traffic accident or is it diabetes related cause of death? Not easy, you know? Yeah. So things, huh?
You have primary and secondary.
Yes, but again, I go back to the story. If he didn't have diabetes, he might have survived because the infection will go. Oh, sorry. Time's up, is it? Okay. Yes. Yes. Ambulatory care sensitive condition. Yes.
Die of diabetes or do they die from like a heart attack? But this, let's just say your heart is affected by diabetes. So, I mean, how do you die of diabetes?
Okay, there are two types of diabetes. There's acute and chronic. I think I'm not sure you covered it up. Acute will be two things: too high, too low. So if you're too high, you can go into hyperglycemic shock. Yeah. So there's this thing called HNNK. That when you have high sugar level, that can go to coma. That's acute causes of death. Then there's another one is called hypo, where you have too low a sugar, maybe because you got diabetes, you go inject yourself with insulin, then you still check your sugar. Yeah, still so high, inject some more. Still so high, inject some more, then forget your machine is spoiled. Then keep injecting and they're very happy. After that, now very happy, 0.1. Then you die. Yeah, because the sugar is now too low. Yeah, so be patient. You inject, wait a while. Don't go and inject and check again straight away. Please wait a while, okay? So same your blood pressure, okay? Don't like check your blood pressure high, then take medicine, check still high, take medicine, keep taking. And that's not a way to do things. So yeah.
Go to the doctor if that's the case.
Okay, same thing. So don't jump to conclusion. Okay, so the key is that if you have diabetes, acute causes of death will be the hyper and hypo. Yeah. Then there'll be chronic causes. Chronic causes will be things like amputation, for example, things like kidney disease, kidney failure, or you have ulcer and infected, or all these complications, eye damages. But the diabetic retinopathy generally don't die. So the eye don't die. But kidney can die. You just go blind. Okay, the thing about diabetes, there's this thing called macrovascular and microvascular. Macro is big vessel. Big vessel is vessels to the heart, vessels to the leg. So big vessels will be getting heart attack, or leg you get amputation, or you get claudication pain, or means not enough blood flow. That's big vessel. Small vessels to the eye, go blind. Small vessels to the kidney, they get kidney failure. Okay, so this is a simplified version. Next, you have age-specific mortality rate. Because at each age group, the death rate is different. So we talk about age-specific, need to adjust by age. Some talk about gender-specific. Yeah, he also gender by gender-specific. So again, time, place, and person. Okay, so this is kind of like what's the cause of death? This is the age-related. Okay, yeah. Okay, so maybe I'll stop at 2:50 so we have some questions. Okay, I think this is the last thing I'll cover before I stop. Okay, what is called relative risk. Okay, so we talk about relative risk is new cases of disease among the exposed to the new cases among the unexposed. Because of this, you need to be a cohort study. You cannot be cross-sectional. This doesn't have cross-sectional. Cohort study because you need to have a group of population that doesn't have the disease at the start. That's why for those without the disease, then they have a chance to have incidents, new cases coming in. So what is a cohort study? This is an observational study. Just mentioned about experimental study, quasi-experimental. So the correct term is called observational. So you don't do anything, you observe. Okay, you observe the patient. So it can be retrospective or can be what's the word called? Prospective. Okay, it's here. Okay, so prospective means forward-looking. So prospective study means I recruit a group of 15-year-old. Okay, then I watch them over the next 10, 20, 30, 40 years. So you want to have a lifelong stability job, right? Be an epidemiologist. Then you tell the grant person, I'm going to do a 50-year study on 15-year-olds. Then these 15-year-olds, some you give them a candy bar, some you don't. Then after 50 years, you see that 50 years ago, those who took the candy bar and took it are found to be more successful than those who took the candy bar and then don't take it or took extra candy bar. Okay, this is a long-term study. Okay, but you see a problem, right? It's so long. Yeah, so that's one of the issue. It can also be retrospective. Retrospective means you look at those who are successful now. Look back 20 years, 30 years, what did they do? Which school did they go to? Raffles, Laban High, Ray Swastika. Okay,
Elitism.
yeah, that is a retrospective study. So look at the outcome, then look back, okay? Or whether they had breast milk when they were young or your formula feeding. So there are some studies, you can go and search, that formula fed children are bigger size, obese, and higher chance of diabetes. Okay, so you can realize nowadays, more and more children are being bottle fed. Okay, agree? More and more children are being bottle fed, means fed by in formula. Obvious, because so many formula company price going out, right? More and more children are overweight. More and more children have childhood obesity. More and more children have childhood diabetes. Is there a link? This is called ecological question. We don't know. That's why you need to design experiment. So you want to do the gold standard, you get a group of babies, one group, okay, you randomize. One group, you give them breast milk. One group, you give them formula milk. Then you watch them for 10, 20, 30 years. Who is obese, who is not obese, who get diabetes, who don't get diabetes. This is how you do the study. What's the challenge?
Ethical.
Correct. You need to make sure that they have the same thing. Otherwise, the group that drink breast milk later have chocolate McDonald's. So there are a lot of things that can happen over the time. That's why all these studies are very prone towards this thing called confounding, or okay, cover that. A lot of other things. So you need to do adjustment. So make sure that the one for if you're talking about obesity, make sure that they exercise the same. So you go and ask them, okay, how much exercise you do. So then you compare, they do a matching. So those we do 60 minutes exercise, bottle milk, breast milk, then compare. That is more fair, right? Because exercise is similar. Okay, so this problem with this type of study, and the longer it is, the harder is it to follow through, because a lot of people change address, move house. Okay, don't assume that you enroll in a study, right? If they move house, they'll call you. No. Then 1 year later, 5 years later, you call them, you're not there anymore. They have lots to follow up. Okay, so all these are the biases. Okay, I will stop here. I shouldn't go too much. And then we'll have okay, now we have about 10 minutes for questions about today. So today we have covered, firstly, we have covered what is epidemiology. Okay, let's recap. Can you tell me someone remember what is epidemiology? What is the formal definition?
Informal is place, person, and time.
Okay, easy to remember, right? So that's the thing about formal, informal. Do you want something that is so accurate, so scientific, but very hard to remember, or you want something easier to remember? Okay, So that's the first thing. Good time, place, and person. So when you talk about anything, when you talk about describe any project, diabetes, you talk about time. What is the trend? Place. Which hospital more diabetes? Which community? Yishun, Woodlands, Toa Payoh. Person. Who are the one getting diabetes? The Malay, the Indians, the foreigners, whatever. So just think of these three things: time, place, and person. Of course, there are other things to think of, but these are some ways you can talk about. We talk about epidemiology. Okay, the role of epidemiology in public health. What are the 4 roles? Or what roles can you think of?
Strategy for policy.
Good. Strategy. What else?
Disease surveillance.
Yes, disease surveillance, flu vaccination, flu strain. What strain is it? COVID strain. Yeah. What else? 2 more. Huh?
Evaluation of
Yes, evaluation. Yes. One more. Last one.
the risk factors.
Yes, the risk factor. Yes, very good. Wow, I have not wasted my time. Very good. Okay, the 4 roles. Okay, monitor, describe health status, which is what you did. You describe about ACSC, right? You say what are the conditions, who gets it, things like that. Remember, where are they from? Yeah, risk factor for diseases, vaccination. Remember, vaccinated, not vaccinated. Public health policy and strategy. You can talk about should we social distance or should we do isolation? These are different policy to talk about. Yeah, then there's in during COVID there was this dance strategy. The dance strategy is you tighten. Okay, then the number of cases drop, right? Then you loosen. Then whenever the case increase again to a certain level, you tighten again. What does this sound like? Singapore. That's what Singapore did, remember? We wanted to have the easing, remember? We ease, right? Then somehow, I think Ong Yi Kang or Lawrence Wong, can't remember who, cases went up. Then we tighten again, remember? You all forgot already. Yeah. Then after we lose again, then tighten again. Yeah.
2 to 8 and then to 4.
Yes. So Singapore actually followed that strategy. I think it's come with his name, but this guy is called the elephant and the dance. You can Google it. It's called elephant and the dance. I don't think I'm not sure if it's epidemiology, but this is an idea. Makes sense, right? You change your strategy based on the problem that you have. Okay, so we cover a bit of disease frequency. Okay, disease frequency only covered 2. What are they? Anyone remember? Yes, and remember incidence has a N. Okay, because incidence has an N, it's always about new cases. Yes.
Number 1, there's this per 1,000 person year. What is the concept of year in your formula?
Person time. Because you need to have that because it includes the period also.
Oh.
Because a rate is always a time. There's a time element. So what they do is you do a person year. For example, let's say you talk about Singapore population, you can multiply by 1 year. You use 1 year, very simple, because our population is 1.5 million residents, right? So 1.5 residents times 1 year. So the incidence in that year is that. That's the point prevalence. Okay, or you can talk about period prevalence, which is in that 1 year, what is the number of new cases with the disease? Yeah. Okay, but very good point. Just remember there is always a period you need to talk about. Otherwise, it doesn't make any sense. Because, okay, so that's the problem. I jump, what did I jump? Okay, incidence rate. Say, cumulative incidence, then you talk about the proportion over a period. So there's a period involved. Okay, usually it's 1 year lah. The incidence usually talk about 1 year. That's why we may sometimes shortcut. Let's say the incidence of diabetes is I think it's 30, no, less than that. Incidence of prevalence is about 0.5%. 0.5% in Singapore population of 6 million is how much? 3,000. I think there are 3,000 new cases of diabetes every year. Or 30,000, I can't remember. 3,000, doesn't matter. So there's the number of new cases in 1 year. Okay, so that's called incidence. There's an N inside, new cases. What's the other one? Yes, prevalence. Is there N or not? And there's also an N, but N is here. Okay, so anyway, incidence, the N is earlier lah. So the new cases lah. Okay lah, never mind lah. Okay, 2N lah. Okay, 2N. So 2N is new cases. It's only got 1N, so it's existing cases, prevalence. But over time, remember lah. Over time, remember. Yes.
Remember, prevalence is the stock, right?
Yes, stock and flow. Yes, new cases and stock. This one is more of operation research lah. Yeah, this is how many you have in the current stock, the new prevalence cases. Okay, and then incidents of new cases coming in. So the problem with a lot of screening, right? When you talk about screening, right, you actually uncover. Okay, when you talk about screening of, let's say, diabetes, who are you likely to pick up? New cases or existing cases? when you do screening for diabetes?
Existing would
Because existing is a bigger reservoir. Okay, let's say diabetes, let's say okay, there's a formula, it's called prevalence equals incidence on number of years of disease. So let's say diabetes on average you get 30 years of diabetes. So your prevalence is actually your incidence times 30 because just on steady state, this is the formula. So whenever you screen for diabetes, if you exclude those who already have diagnosed diabetes, what you're picking up are the undiagnosed cases. The undiagnosed cases, some of which may be new cases, but more likely than not, because the undiagnosed cases is bigger in number. Therefore, if by chance we go and screen, you're more likely to pick up a patient that is have this condition for more than 1 year. What this means is that your screening program most likely will pick up patients that are sicker than new cases. Okay, new cases mean very simple. New cases means you screen every year. So this year I screen NHG. Okay. Then 1 year later, I screened again and found that Gary has diabetes.
oh, no.
That is a new case. And I only had it for 1 year. Why? Because last year I screened, I don't have diabetes. So this profile is very different from just a screening program. Because screening program just screen like that. They don't know whether last year they have or don't have. So they found that so that's why when they did this and they tracked their sugar level, they found that a lot of these patients have diabetes more than 1 year. Yeah, they're not looking for new cases, they're looking for existing cases. Yeah. So this is one concept. So when you do any screening program, you'll likely pick up people who are sicker in the sense that they have the disease more than 1 year. You're not likely to pick up the real new cases. But a lot of studies, when you do this population study, right, what they do is they do the test every year. So the new cases they pick up are really, really the very new cases. So very likely milder. That's why there's some biases when you talk about this. Yeah. Okay. I think I covered that all. That's why I cover. Okay, mortality rate, death rate, right? So I cover 3 types: death, crude, cause specific, age specific. Okay. Just remember you can only die once. So it's most likely talking about incidents. Okay. But having said that, right, there are people in our database, right? Okay, they died maybe 2007, but they still appear in polyclinic. Very scary, right? Yeah, this is called data inaccuracy, so it's not real. Yeah. Or there are some cases where people die, right? They use the card for CHARS claim. Happened before. Yeah, somebody died, they still use the card for CHARS claim. That's why you do have people who died and still claiming. Yeah. And it's not funny, it's sad, but this is real. So there are people, even in India, there are people who died and they use the person's IC to go and claim the pension. So you die already, right? 10 years later, still can someone claim the pension. Yeah, so this is why you need to update your data. Because if you can use the cert to claim to do this, it's just like me, I was a student, right? I still use my student pass to claim. So when you go and do, let's say people who claim, let's say every student claim, right? They found that, how come there are 10,000 students when there's only 8,000 students that enrolled? Why? Because people who are no longer student like me, still using the student card. Okay, so that's why you need to cut the access. Make sure that every year you check, are you still a student? Otherwise, you end up this problem because the shop wants to help the people give discount, right? So I ask NTU, how many students you have? Oh, 8,000. 8,000 only. Okay, 8,000. Then you realize, how come 10,000, 20,000, 30,000, 40,000? Every year number keep growing because existing student go, non-student, graduate students still go. So same idea. So for death, right? Not so straightforward. In our database, a lot of people who died still have utilization. It's very, very scary. Yeah. So that's why I need to clean the data. Okay. We cover one more thing to cover is relative risk. I think we already covered this again. So relative risk is about more of the cohort study. Okay. So I shall end here. So next week we can cover this again. Okay, so I'll give a quick preview. We'll cover odds ratio. I think you cover odds ratio today, the odds of having the disease. Okay. A bit different. This is more for cases and control. We'll cover about data collection. We'll cover about the descriptive, analytic, predictive, prescriptive. This is some. Have anyone seen this?
Survival bias.
Okay, you know already. Very good. Wow, so ahead of the time. Okay, this is week 2. Okay, maybe more turn. So I'm too slow already. So week 3, I'll cover descriptive epidemiology. Haven't done the slides yet, but this is what I'll cover. Week 4, I'll cover disease frequency and burden. Okay. Week 5, I'll cover more of association, more detail, what is risk and all this. Attributable risk, population attributable risk, Hughes criteria Okay, this one is a famous question. Yeah, there's eight laws or 9 laws, don't know how many laws. That I'll cover this. Different type of studies, ecological, cross-sectional, nested case control, and all this, RCTs, intervention studies. So basically, there are descriptive studies, there are analytical study, intervention studies, and then week 6 talk about bias, confounding interaction. Week 7 talk about data collection analysis. That's it. So these are all what I covered. Okay, I shall stop now. How do I stop? Okay, let me stop recording. Yes.